Hey guys, welcome back to the Foam Frat podcast. This is actually not a podcast. This is a phone conversation that you're going to listen in. Not really. It's a podcast. But I want you to frame it that way because this is my buddy Bryan Winchell. You guys have seen him before. I call Bryan all the time. I got ventilator questions. We pick each other's brains on stuff. I have him peer review stuff that when we put it out that's ventilator related. And we have a lot of, I think, really valuable phone calls where we're basically just BSing with each other about ideas. And neither one of us are claiming to be a vent expert, but it's something that we're passionate about. We talk about a lot. I just think that we find it really interesting. And so we recently were talking about PEEP, and I had some theories on PEEP, and Bryan has some ideas on it. And I was like, all right, let's just pause this phone call and let's just record this as an actual podcast because I think there may be some value in it. And more so than like us trying to like teach people things is we want to stir this conversation up and we want you guys to let us know what you're doing. Let's talk logistics of this. Let's do a follow-up episode with somebody telling us that we're full of crap. And let's stir that up and see if we can try to get some more conversation going. Because I had a call, and it's far enough in the past that I feel like I can talk about it now, and it's not going to be like a HIPAA problem, where we went into a facility for a patient that they could not get their SpO2 above like 70%. Mm-hmm. And we walked in, and the PEEPs are at 20. They're in a pressure control mode, and they're like, we cannot get this patient's SpO2 up. And they said that it was like an influenza A, and they were thinking maybe it was starting to go towards ARDS. But in reality, the patient had only been in the emergency department a couple hours, started off on BiPAP, and then they actually had to intubate because of mental status deterioration. And so I'm walking in, and I see a PEEP of 20 and SpO2 of 70. I'm going to say the I time was like 0.4 seconds or so. And my first thought is like, wow, that's a really high PEEP in the emergency department. Like maybe in the ICU, you see PEEPs that high, but in the emergency department, we got there really quick. And so I don't know why, but I came down a little bit on the PEEP. I went down from 20 to 15. And we saw an improvement. And I'm really shortening the story. But then we went down to 10 and the SpO2 got even better. It was like up into the 90s. And I was like, what in the world is going on? Like typically we're doing everything we can to hold recruitment. You know, people are clamping the ET tube when they disconnect it. We're guarding that pressure with everything we have and that PEEP and that recruitment. And this patient actually responded to me turning down the PEEP. And I had never came across that before. And you probably remember when I called you and told you about that, don't you?
Yeah, it was definitely confusing. And I'm trying to remember, Tyler, when we talked about this case, at the same time, were there other manipulations that you did to increase your mean airway pressure? Because I noticed you said the I time was 0.4 seconds. Do you attribute that the stats got better to the decreasing of PEEP, or do you think you attribute that to some of the other things that you were doing to increase the saturations?
No, yeah, that's a great question. So I'll preface it by saying when we got there, they said, we've already tried APRV and they failed APRV. Mm-hmm. The only thing they hadn't done yet is proning. But I mean, they were given nebs. You can name everything they were doing. But when I walked in, I noticed that I time's short. Like for us to be at 20 a PEEP, I feel like we're not working smart with our mean airway pressure. And so I did two things at once, which is probably like the cardinal sin, but we always do that when we are adjusting ventilator settings.
It's hard to sit on your hands.
It is. It's hard to be like, well, let's do this and see if this works. So I did like two things at once. I decreased the PEEP from 20 to 15, and I took the I time up to like 1 second, maybe 1.2 seconds. And I saw an improvement. And I was like, oh, cool. And I think in my head, I went back up with the PEEP to 20, and I saw it actually get worse again. So then I went back down to 15. But yeah, I was doing like two things at once, and I wasn't sure which one was actually helping the oxygenation, but something was helping. And then when I went from 15 to 10, that's where it's like, oh my gosh, okay, this is starting to make sense. Like either this patient has a patent foramen ovale, or the patient is over peeping and we're actually like distending the alveoli, clamping off that pulmonary circulation and creating like iatrogenic dead space by over peeping. And so it was one of those calls where you think about it forever. And I thought, you know what I'm going to do is I've had calls before where I have an FiO2 of 100% and I'm turning up my PEEP and I'm turning up my PEEP and it's not getting better. And I started learning more about inspiratory time and the role I time has in increasing mean airway pressure. And I attribute a lot of that to stuff that you taught me. And so now I have a stop point. I like stop at a 10 of PEEP. Not saying I won't go over that, but I stop and I go, okay, am I working smart here? Because I don't think most of us need much convincing to go from 5 to 7 to 10. But then when you start getting into like the 12 to 15 to 20, it's like a whole new level of commitment. And I want to make sure that I'm doing it smart and I'm working in the right direction and I'm not buying mean airway pressure purely by increasing PEEP and thus increasing if you're in a volume mode your plats or if you're in a pressure mode your pips. And so that's what I wanted to talk about. And I wanted to see what your mental model is on two things. So like one, how high are you going up with your PEEP before you start increasing your I time? Are you doing those both at the same time? And then two, if you walked into an ED and the patient had been there for a few hours and you got a PEEP of 20, does that get your spidey senses tingling a little bit that maybe we performed our recruitment maneuver, we got those alveoli recruited, and now we just pushed them past that distension point?
Yeah. Wow. Two super good questions. I guess we'll start with the first one, which is how do we adjust for oxygenation? And, I was taught, like many were taught, that when I think about ventilation, I think about CO2 and I think about minute volume. When I think about oxygenation, I think about gauging that with my PO2 and my SpO2 and then adjusting PEEP and FiO2, whether we use that ARDSNet table or something else. And I think just in the last few years, we've sort of expanded that knowledge to say, maybe it's more about mean airway pressure as more than just PEEP, which you mentioned. And I think that is super important. And there's essentially four really large parts of mean airway pressure, or as they call it on the Hamilton, the P mean, whichever nomenclature you prefer. So PEEP is one component of that. The other is your I time. That's another large component of it, or your I to E ratio. So the longer you hold that higher pressure, the more mean airway pressure we have. And then, of course, respiratory rate doesn't at first make sense until you realize that's just more of the higher pressures happening in a minute. And then your peak airway pressure is also that component. So there's other like tiny little pieces of that, but those are the big four. And so when I walk in, I think the thing that would alarm me even more than that PEEP of 20 would be that I time of 0.4 seconds. I'd think, wow, why is it so short? And it's really easy to do that if you're if you say you have your ventilator in a 1-to-4 ratio by default, and you've just brought that rate up chasing your CO2, and maybe the rate was 26, 30, that you can get to a 0.4 pretty quick. And one of the first things I'll do is I'll extend that I time out and then bring the rate down as if I have to deal with the air trapping. So I think that was a smart move. That's one of the first things I do. And oftentimes when you walk in and you see someone with high peak airway pressures, simply increasing that inspiratory time lets that airway pressure lower a little bit. And I think of it like a BVM. So when you're holding a BVM in your hand and you've got somebody that's hard to bag, what do? Well, intuitively, we just squeeze slower, right? We still want to kind of put a decent volume in, but we give it over a slower amount of time. And that's exactly what you're doing with a longer I time. So if you think of pressure ventilation as just literally a BVM and watching a manometer, you're just squeezing that BVM till the little needle on the manometer comes up to the yellow line or whatever, and you're right at 30, and you just kind of hold it right there until that breath is complete, and then we let it off. And inverse ratios, I think I've become a lot more comfortable with. And you can pause me if I'm rambling here, but I think when I was trained about inverse ratios, I thought of 3-to-1 as the ratio, and that meant there was obligatory air trapping. And so a lot of times I've realized maybe 1-to-1 is a really safe place to start in someone with failure to oxygenate. It's problems. And I'll start in a 1-to-1, and then I'll just increase that ratio to a 1.5-to-1, to a 2-to-1, 2.5-to-1, watching a flow waveform and making sure that they're exhaling that mostly to baseline. And that's even a rabbit hole I think I'd love to get more opinion on some other time. But I think letting that come all the way to baseline is super important in an obstructive patient, or a patient with more like bronchospastic physiology. But I don't think it's quite as important in someone where you have high levels of PEEP as well. So just making sure that you're not air trapping and your tidal volumes are staying consistent helps me know that my inverse ratio isn't causing hypercapnia. So I would be pretty quick to begin inverse ratio ventilation, and then kind of adjust those other parameters. If you have a Hamilton, one of the crew members at our program figured out, when you're in pressure control ventilation, there's 4 dials on the control tab, and it goes respiratory rate, and then pressure control, and then PEEP, and then I time. We think of that like a clock, and you can just kind of go around that clock. Those are the 4 parameters that really change your mean airway pressure as well. As we kind of optimize one, move to the next, optimize the next one, take stock, see how we are. And you might go around that clock a few times until you find the right amount of each thing. And I think that's what you're getting at here, Tyler. And I'll hand it back to you with this. Each of those components of mean airway pressure, whether it's PEEP or your peak airway pressure, your I time, sort of need individual attention. You want to optimize each one of those independently for the patient. And you might have a patient that requires 20 of PEEP. And that might be the ideal amount of PEEP for that patient, but oftentimes it's not that high. And I think that number of 10 isn't a bad number, especially as you're coming up to say, wow, I'm crossing 10. Am I checking my other boxes? And then the question becomes, how do we know what the right amount of PEEP is? And I think that's where I'm here as a learner as much as someone who's been studying this for a while, because I don't think the literature is very clear on it. And that's a big question I have. How do we know what the right amount of PEEP is?
Yeah, that's you bring up a lot of good points. And I love what you said about the inspiratory time and the things that you've taught me about inspiratory time. Because I remember early on, before I was flying, when I was working on the ambulance, somebody told me you recruit with inspiratory maneuvers and you maintain with PEEP. And I remember thinking, that's really interesting. And when you look at like the theoretical way that you dial in, the whatever an ideal PEEP is you want to get the alveoli to where they're open, but they're not over distended. And in the blog I put out, I had my daughter blowing up a balloon, and there's the overcoming surface tension, and you start blowing into it, and you feel like you're blowing really hard, you're not seeing anything. And then all of a sudden it starts to take form, and you start to see more changes in volume for a given pressure. And that's that lower inflection point that we talk about. Mm-hmm. And then you keep blowing in the balloon, and then you get it really big. And then all of a sudden you're like right back where you were in the beginning, where you're putting a lot of pressure in, but you're not seeing much change. And that's the area that we want to avoid. And theoretically, we want to try to get our PEEP right above that minimal closing pressure. Right. But it's hard because, we're talking about healthy lung. And in the diseased lung, maybe you recruit these ones at this pressure, but these ones aren't going to recruit until they get up to this pressure. And these ones aren't going to recruit until they get up to, 40 centimeters of water of pressure.
Yeah.
And so you don't really know. And that's why like the time controlled ventilation, like the TCAV model, where you're giving a longer inspiratory time and you're holding that pressure. I mean, you can see videos of those little mice, like atelectatic lungs that just pop. They all pop open, but they don't pop open at once. It's like they all pop open slowly. And that's like such a huge point, because we may be setting our PEEP at, let's just say you set your PEEP at 10 and you have an I time of like 1 second. That may still not be enough to recruit some of those diseased alveoli. And so there's so much that we don't know. And that's why I think like airway pressure release ventilation, or APRV, makes a lot of sense. But when you're trying to dial in your PEEP somewhere between the lower inflection and the upper inflection point, it's more so, like you said, a teaching point than something we can actually logistically do in the back of a helicopter. Because if you're using pressure control ventilation, the pressure volume loop doesn't really give you much information at all. Like it just it just starts cutting off your breath because of your alarm limits or wherever your PIP is at. And even in a volume ventilation, your patient has to be paralyzed. There's so many factors, but it's a cool way of teaching it. And you're like, oh, okay, so I just have to get it here. But in reality, you don't really know. And so there's a couple like inspiratory maneuvers. There's like the stair step or the stepwise fashion where you start off really high and then you start slowly titrating down your PEEP, and then when your SpO2 drops and you're like, oh crap, that's the point where I'm starting de-recruitment, and then you go back up. There's all these different ways of dialing like what that ideal PEEP is, and 10 is just a round number in my head that I stop and I go, okay, are we doing this smart? Am I working smarter or harder here? Like what am I doing? And then I still at that point, I feel like you start slowly extending your eye time out until you become like inverted. And once you're in an inverted I to E ratio, like I don't see any point in not going to APRV at that point, unless you believe that your patient, which I think is true, like typically a patient in APRV shouldn't be paralyzed, according to like my mental model, so that way they can breathe on top of the T high. But it seems like they just naturally bleed into each other. Like you're increasing your eye time, and then eventually it like leads you to go, hey, maybe we should switch to APRV or prone or something like that.
You know, one of the things that you mentioned early on I thought was interesting is you said that they failed APRV. And I think that's super interesting because APRV is a mode that has just a wide band of application, right? They could be paralyzed, they might not be paralyzed. Who knows what their T high was? Were they using Dr. Hibashi's TCAV method where you have a P low of 0, or did they have an optimal timing on it, et cetera? So to me, that doesn't tell me a whole lot that they failed APRV. You know, that means you could set up APRV to look like pressure control ventilation with an ID ratio of 1-4 and it wouldn't be doing anything, you know? So I think you bring up some good points that continuum makes you think, hey, if APRV is in my toolbox and I'm already inversing my IDE ratio, maybe I should think about progressing to APRV. I do think the TCAV method has a lot of merit. And as you look at the literature, it seems to have a lot of literature published on it supporting it. I love the videos you mentioned, and just the idea of how it takes time to recruit that lung, and that kind of that slow breath at that higher pressure helps recruit that lung. And if you've ever done a pig lab and you're listening, and if you think about that in your head, and you do those pig labs where you put a PEEP valve on and you see that the lung doesn't collapse as much, that there's some value in that. You know, there's no chest wall on that, of course, so that changes the dynamics a little bit. But at least the value of thinking about how that inflates during the inflation period is super important. And then also, I think realizing that it's sort of a viscoelastic system. In other words, there's some inertia in the lung. So once it's inflated, it doesn't just immediately collapse to nothing. That it takes some time to collapse. And that's where, if you have that inverse ID ratio, you're kind of up at this higher pressure. You relax just enough to let some CO2 out, and then you come back up to that pressure, and you're trying to keep those alveoli inflated. And I think you can meet a lot of goals in conventional ventilation with the right amount of PEEP and a good mean airway pressure and a good ID ratio and a good rate. And I think if you're comfortable with APRV, that is another option. But of course, we're here talking about PEEP, so we're really talking more about conventional ventilation, I think, tonight. And you mentioned 10 of PEEP as kind of a stopping place. Maybe in my head, I might think of it maybe as a starting place. I'm not sure. That might be a little bit different than how you think of it. But if I walk in on a patient, maybe like yours, maybe they just intubated them or their vent settings don't seem ideal, I think of starting at 10 of PEEP as a place to start with someone that has poor oxygenation. And then I'll kind of work that dial around and say, okay, now I'm going to bring my eye time up and get my ratio a little bit inverse and make sure I'm not air trapping, and get my PIP to sit right at 30 and bring my rate up to where I want it. And then I'm back to the PEEP. And so now we're at the question of, do we keep going up on the PEEP, or how much do we go up on the PEEP? And I don't know if this is how you do it, but the way it works in my head is oftentimes I'm in pressure control on these patients because I use a Hamilton ventilator, and the Hamilton ventilator inside it is a pressure ventilator. And even if you're in one of the pseudo volume modes, it's PRVC. And I don't want to wait for the algorithm. I'm a little impatient for that. I want to see the results right away. And so I'm in pressure control ventilation. So my my mental model's based or predicated on that. Um, what I'll do is I'll start bringing the PEEP up slowly, maybe 2 clicks at a time, and I'm just watching the tidal volumes. And if the tidal volumes start dropping, those are red flags to me to say, are they dropping below a point that I feel comfortable? Now, if we're still between 4 and 6 cc's per kilo and our permissive hypercapnia is in a range where we're comfortable with that, I'm good with dropping that volume a little bit. But when I get to the point where I'm uncomfortable with where the volumes are, maybe they're dropping to 275 on an adult patient, I think maybe I've over distended a little bit, or maybe I need to come back a little bit on my PEEP, and I'll kind of hold what I've got. And then the other thing that I think about is that might be the ideal level of PEEP right now. But in 2 hours, I might be able to get another 1 or 2 centimeters of water of PEEP on the patient. And maybe in another 2 or 4 hours, I can get a couple more. And so, our medical director is an intensivist, and it's not uncommon for her to live in the 14 to 16 range, but she doesn't get there in the first 2 hours of care. That's something you get to over time. And so I think as a clinician on a helicopter, I want to fix everybody and I want to have them all perfect by the time we get to the receiving. And that doesn't always happen. And so to me, finding the optimal PEEP may not be exactly what's optimal for that sick lung at that time, but it might be the best that I can do with the hour that I have them. And that's my method of doing it, is watching my tidal volumes and bringing the PEEP up about as high as I can until those tidal volumes drop to an uncomfortable level. Does that make sense to you? Or do you think, do you have a different model, or what are your thoughts? How do you do it?
Yeah, no, that makes a lot of sense. While you're talking, I was wondering what SpO2 are you targeting? Because I think that could be another thing where you start trying to hit an ARDS patient at 100% SpO2. And I think that means like diminishing returns super quick.
Yes.
And one of my buddies said, he said, I'm trying to think of God, what is his name? I can't remember, but he says that nobody ever died from a bee. Like, you should be okay with an SpO2 in the 90s.
Yeah.
And
Yeah, 100%.
I think that's true. I honestly think that's true. Like, what is the SpO2 that you're trying to target?
Well, and COVID's really shaken that up for us, right? Because I think with people with coronavirus, I target a much lower SpO2. And I've almost had to, we recalibrated a year ago, right? All of a sudden, sats in the 70s were, okay, that kind of is what it is, And then all of a sudden, we're starting to get some of these ARDS patients or CHF patients that don't have COVID. And all of a sudden, I'm having to readjust and say, oh man, that saturation of 80 really actually needs to be addressed a lot quicker because they don't have coronavirus. This is not a happy hypoxic patient. And so I think it is disease dependent to a sense. But my thought on the pulse oximetry too is that SpO2 is just a non-invasive surrogate for PO2, which is kind of what we care about. And so having that recent gas to know what the PO2 is tells me where it's correlating to my SaO2. And so if my saturation is 85%, but my PO2 is climbing towards 60 or 58 or 60, I'm a little bit more comfortable with that as opposed to a PO2 of 48. And so that whole left shift, right shift of the curve just tells me where my SpO2, which is non-invasive and what I have in the helicopter, intersects with my PO2, which is what I set my goals off of.
No, that makes a lot of sense. It was Vahe Ender. I don't know why his name didn't pop in my head, but he always says nobody ever died from a bee. Like, that 90% is probably an okay place. 90, 93%, somewhere in there. I'm fine with that, especially if the chest X-ray looks like garbage. What's that?
Or less. I think high 80s is
or less than that. Absolutely. Now, when I first started like critical care transfers, I remember everything was like the ARDSNet trial or the ARMA trial, the ARDSNet research.
Yes.
And they had that PEEP FiO2 chart where it said, like, if you had a FiO2 of 100%, you had to be like 24 a PEEP. And like, I think we all quickly figured out, like, that's not true. Like, you don't have to be at 24 a PEEP at 100% FiO2. But there's still a lot of people that go by that chart and think that, if you're at 30% FiO2, then you can't go past a PEEP of 5. And so I think that chart is often misinterpreted. And so I just wanted to bring that up because that chart is predicated on very, I don't want to say old data, but it's the 1995 understanding of how recruitment works. What is your thoughts on that PEEP FiO2 chart?
Yeah, I agree. My understanding of the literature is that's a consensus statement that came from the 90s. And I think it does have some value. I think the downside is that it's only two components of that oxygenation metric. And so we're tying just PEEP and just FiO2 to oxygenation. And, as you and I looked at how to set optimal PEEP as we kicked around the literature, and we can put some of these in the show notes, there's a million different ideas of how to find the optimal PEEP. I mean, it ranges from CT scans to esophageal manometry to looking at static compliance and driving pressure and tidal volumes. There's so many ways. And I think one of the things that it opened my eyes to is it's easy to just tie the optimal PEEP to oxygenation in my head. And I think that's a little bit narrow-minded. And I've tried to expand outside of that. And maybe PEEP is a component of oxygenation, but I think it's helpful to uncouple PEEP and oxygenation completely in your head. Your goals with PEEP are more than just trying to meet a certain SpO2. And I think that's the downside of that FiO2 PEEP chart is you're only looking at two ways to optimize your oxygenation. So it's like it's giving you a hammer and a screwdriver when you actually have a toolbox full of tools that you could use to get there. So one of the things that we found most valuable, and we this was a change we made on our ventilators during the coronavirus pandemic here, is we actually put the mean airway pressure as a large monitored parameter on the screen of the Hamilton. You can set up those 4 monitored parameters. You can customize them. And we put the P mean as one of them right under the peak airway pressure. So we have a peak airway pressure. So it's right on the top and we're thinking about it and trying to maintain it 30 or less. And then right under it, we've got P mean. And what that did is it just opened the eyes of our clinicians to how all the little micro adjustments we talked about, rate, PEEP, eye time, peak airway pressure, adjust the mean airway pressure. And of all the things I couple in my head to oxygenation, that's what I'm using right now. And I don't think that's perfect. I still think it's kind of it's a crutch, but I need some crutches in the helicopter. I need a lot of heuristics because there's only so much data I have to work with and so much that I can do. And so for me right now, I watch my P mean as what I chase to get my oxygenation up. So you said, what's my target? Well, if my target is going to be a saturation of 88% and I'm not there, I'm going to do what it takes to get my P mean up so that as it climbs, my saturation climbs with it. And that might be different for each patient. Now, if I have a healthy lung, I don't really care a lot about the P mean. But if I'm worried about oxygenation, that's my go-to for saying, how am I doing? How can I get it better?
Yeah, that's interesting because I found in unhealthy lungs, you typically have a smaller time constant. Like they exhale pretty quick. You're not, unless it's concomitant with some sort of bronchial constriction, or
Sure,
they could only
sure.
get a 5.0 ET tube in. But for the most part, they exhale pretty quick. Like your
And you have smaller
RCX.
volumes.
Yeah, exactly. And so, yeah, exactly. It's smaller volumes, and you probably don't have the best recruitment, so they are able to get rid of that air pretty quick. And you see that flow waveform. If you have a flow waveform to look at, you see that come back to the baseline. And you've taught me to identify like that no flow zone as like, oh man, like there's all this stuff I can do with that area. Like I could increase the rate, the minute volume, the mean airway pressure.
Yeah.
And so that's something that I really think is important, because looking and seeing that no flow time and then thinking in your head, okay, this eye time is 0.3 seconds, the PEEP is 20, and I'm just sitting here for 3 seconds not doing anything, or 2 seconds not doing anything with this breath. It should be that obvious, but it's not, because we're not always taught that stuff in critical care paramedic training or whatever. We're not taught to look at those things because not all the ventilators had them, but we're in a new era now. The ventilators do have them. The T1 tells you that. And I like that's got to be something that we just put in our heads. Like we need to see those. We need to titrate it off of those. And it should just be that obvious. It should be like when you walk in and you see a third trimester pregnant woman on a longboard laying flat, and you're like, oh my God, okay, let's lay off, let's roll you off to one side. Like, it should be that obvious what to do. But even in my eyes, I can look back to like when I started at Lifelink 3, and I hadn't trained myself to observe that yet.
Yeah, and I'm thinking about the people listening to this that don't have a Hamilton ventilator. And some of the smaller ventilators for transport do have flow waveforms, and they're somewhat helpful. Maybe not quite as accurate if you don't have a flow sensor right there at the endotracheal tube. But I think we learned even before we had the Hamilton ventilators that there was value to these waveforms and learning them, because oftentimes you're picking up a patient at a facility and they're on a ventilator with waveforms, and you can find the ideal timing on their ventilator, then transfer the settings to your transport ventilator and be a lot closer to what you need. But I do love that concept of time on the table, or that no flow zone, and we can throw some links in the show notes. We have a couple graphics and a little video you can watch, but if you find that time on the table or no flow zone, there's two places. There's on the inspiratory side and on the expiratory side. And oftentimes, the first thing you learn about the flow waveform is that you need to optimize that in sick patients for ventilation, which means pick up that extra time on the table with I time or rate so that you get ventilation. But then this is sort of like second level, because it'll look like on the flow waveform that you have time in the inspiratory leg where the flow has come back to baseline and there's no flow. And I've had crews ask me, well, shouldn't we be using that time on the table? We have this long I time. We're not moving any additional air into the patient. It's just holding the air there. Shouldn't we be using that? Maybe shorten the I time and bring up the rate. And I think my question is are you using it for something? And in that case, you are using it for something. You're using it for oxygenation or for gas exchange. And so the whole time that you're holding that I time out is just higher pressure. And I just think of it like pushing on all those oxygen molecules to get it across all the fluid in the lungs. The oxygen doesn't like to cross that water layer that's in a lung full of ARDS. And so it takes pressure. And so that pressure comes from that inspiratory time, pushing that oxygen, promoting that gas exchange and the diffusion into the bloodstream. And so I think that is the trick with the no flow zone. Is you might have a case where you have no flow during the inspiratory segment, but you're using that for oxygenation. So like anything in critical care, the question isn't always what's the right thing to do, but are you thinking critically about, am I using it for something? What's my game plan?
And that's where, like your ASV modes, like an oxygenation type stuff, they're looking at optimizing waveforms and really ventilation. And that's what we hit on when we talked about ventilating the patient in a metabolic acidosis last time you were on. Whereas when it's oxygenation, you could see where they'd be like, why are we doing this? Like, why are we holding this out? But it's because you're actually observing the oxygenation side of it. No, that makes a lot of sense. Bryan, thanks so much for coming on, man. I appreciate your insight. It's always a pleasure to talk to you. And do you have any closing pearls or anything you want to leave us with? Or do you feel like we covered it pretty well?
No, thanks, Tyler. I do echo what you said at the beginning, that in a lot of ways, this is a conversation between a couple of clinicians trying to figure out the right thing to do, more than us trying to teach a class. And Tyler and I think both would be very interested in your feedback and your ideas. There's a lot of super smart people in the world and intensivists that work with these super sick lungs all the time. And we pick them up in this little transport window and try to figure out how to optimize them. So we're trying to boil down all the wisdom that's out there in the literature and then size up the missing holes in it to figure out what do we do for the hour that we have them. And I think in some ways that leaves us with more questions than answers. So I hope that came across as we talked about this, that we're interested in learning this just as well as anybody else. And what we've learned in the last 5 years, I think we also assume that's going to change even more in the next 5. So yeah, thanks for taking time to talk about it. And I think it'll help us grow as clinicians too.